Welcome to AETCM, the emergency medicine channel. So, presenting the case of 77-year-old male who came to ER with an alleged history of slip and fall on outstretched hand while watering the vegetation at home compound yesterday at around 5 p.m. He was brought to ER by his daughter. On primary survey, the airway maintenance, there was no C-spine tenderness, and on breathing, the airway was patent. There was no presence of increps or rhonchi. There was no presence of any added sounds. The saturation was 97% in room air, and the respiratory rate was 18 per minute. Circulation-wise, the heart rate was 76 per minute, and the blood pressure was 128 by 62 millimeters of mercury. There was no active bleeding, and all peripheral pulses were palpable. And disability, the GCS was E4, V5, M6, and the pupils were bilaterally equal and reactive to light. And exposure, the temperature was 98.6 degree Fahrenheit. We maintained normothermia. And adjunct to
pain score?
Pain score was 8 out of 10. 8 out of 10. And we had given analgesic, we had given injection paracetamol. We had given 1 gram IV. We had given, and we had reassessed the pain.
Okay. See, when you have a severe trauma or severe pain, you reverse the WHO ladder. Okay, that's the one thing, WHO pyramid or ladder, whatever it is. So ensure that adequate pain relief is very important. So the classical teaching of starting off with paracetamol, going up with the NSAID, stepping up with morphine or weaker opioids, then stronger opioids. Rather than you start off with the stronger opioids in these situations, the patient's pain score is above 7 and all. Okay, rather than gradually increasing, you give a better analgesics initially, then you come down. And especially in trauma, the additional thing that you need to consider is a regional blocks. So pain management, what are the components of pain management? One is your medications, then is your regional blocks, then will be a positioning of the limb. Wherever there is pain, the positioning of the limb is the next important thing. So that is the role comes the splinting or whatever slings and all those things why we are using to prevent pain. So the patient will have excruciating pain. Once you give a splint and all, the pain will subside. So you have pharmacological and non-pharmacological methods of pain management, and maybe giving an ice pack. These are all examples of non-pharmacological management of pain. So you have to remember, in any conditions, the patient is presenting with pain. Pain is an important vital sign, and if it is above 7 and all, always consider giving an higher analgesic, specifically in trauma. Reverse the WHO pyramid or WHO ladder. You start off with an higher opioids, maybe a fentanyl or morphine, and then you come down on it. So that's a way of practicing in case of trauma.
So following the fall, he had a pain in the right shoulder.
Okay. So you focus upon the right shoulder examination. So somebody has come with a right shoulder injury. You have done your primary survey. You don't see anything in the major other system except for a localized pain over the right shoulder. So following a trauma, somebody is coming off pain over the right shoulder. What are your possibilities that you will consider?
So we can
common possibilities first.
So we can consider bony injury. So mainly we can consider a fracture in the humerus, neck humerus fracture.
Okay, fracture of the humerus. I will say the most common thing around the shoulder joint, the patient complaint will be a clavicle fracture. So that will be the most common complaint that they will say. I am not saying humerus fracture is not seen, but humerus to get fractured, the impact of the fracture should be more. And if the patient is already osteoporotic, elderly, again 77-year-old osteoporotic, the chance of fracture is very, very high. So that also you can consider. So you have to understand these things when you are examining. So first of all, bony injuries. What all bony injuries you wanted to suspect in this patient? Number two, what all things that you need to suspect will be the other structures around the shoulder joint that can get injured. So bony injury, the most common one will be first will be a clavicle fracture. So where does the clavicle get fractured most commonly?
It's in the medial 1/3 and lateral 2/3.
Lateral 1/3 and medial 2/3, because that is the thinnest part of the clavicle. So that is a part where usually they will have a fracture and you will have a deformity over that area. So that is one. Number two, humerus fracture. Okay, it's a high impact fracture. Yes, you can have surgical neck of fracture, or you can have even shaft of humerus fracture lower down. Fine, then
you can shoulder dislocation.
Shoulder dislocation with fracture, without fracture. Then
So then you can have a rotator cuff tear.
It can be a simple hemarthrosis to the joint. It can be just a hemarthrosis to the joint that is creating the pain, or you can have, depending upon the mechanism of injury, the soft tissue structure you can consider. Which are the type, whether he is a fall on an outstretched hand, whether what is the position of the hand, depending upon that you can decide what type of injury the patient had. What is the most common is the rotator cuff that can get injured during that time. Okay. So now you start examining the shoulder joint. How will you start examining the shoulder joint?
Before examining the shoulder joint, we must examine the cervical spine to look for any tenderness or associated injuries, body deformity or injuries are present.
That you have done already in your primary survey.
Yeah, it was
you
done.
have ruled out a cervical spine injury. Then you start off with a shoulder joint examination.
First, we must do an inspection. We must mainly check about the muscle bulk. The muscle bulk, there was the contour of the shoulder. The contour of the shoulder was maintained in this case, but there was presence of atrophy in the posterior shoulder musculature. There was presence of atrophy.
And another important thing, what you need to do in your inspection is the attitude of the limb. How the patient is holding the hand. Suppose the hand is hold like this. He is unable to internally rotate or touch the opposite shoulder. That is the most common thing that you will see in case of a anterior shoulder dislocation. So attitude of the limb is very important. How the patient is. Usually when the shoulder location, this is the way the patient will the patient will come to the ED this way. So that is what you need to look in for. Then
both the shoulder we will fully expose and compare both
shoulder, contour, everything, whether there is the shape, loss of tone, everything you have inspected from front as well as from behind. Very important, from front you can able to see a simple winging of scapula. In the normal position it might be difficult. Only once you are asking to push over and wall and all you will be able to see. But you can see some deformities, whatever is there, muscle atrophy and all those things you will be able to say.
So there was mild atrophy in the posterior shoulder musculature was present. There was no presence of any bony abnormalities. There was not.
Bony abnormalities we cannot say. We cannot say that the contour was maintained. Maybe you can say that way.
Yes, the contour was maintained.
Okay, then. So you have done your inspection. Next step will be your
palpation.
Palpation from?
Palpation in the joint line.
No, you have to start palpating from the sternoclavicular joint. From here you have to come each bony point, then you have to go. The last point where you need to touch is where the patient is having the pain. So this area will be examined last only. All other areas you should come there, and from behind also here the scapula, everything you need to look in for any bony tenderness, and finally only you will come to the joint. Where the patient is coming, that is always make a practice, otherwise they will not allow you to examine at all, and you have to examine that area only in the last. Okay. Inspection, palpation, then next.
So then about the range of motion.
Okay.
The range of movement, we do the forward flexion. The forward flexion.
What are the movements that is very important in a shoulder joint dislocation or any shoulder joint injuries? What are the common movements that you will have?
Mainly the abduction.
Abduction.
Abduction, and we can look for external rotation, and we can look for a forward flexion, and we can look for then internal rotation, and we can also look for.
The most common movements are what you have said.
Yes.
The abduction, flexion, internal rotation and external rotation. These are the major movements around the shoulder joint.
Yes.
Then.
So then we will be looking about the scapular motion. About the motion abnormality, whether there is any winging of scapula, we must look for it. And on palpation itself, we can check for bony crepitus. We can find. There was absence of bony crepitus.
There was no bony tenderness. No bony tenderness for this patient. There was no bony crepitus also for this patient.
Yes.
So probably you are ruling out a bony injury in this case.
Yes,
okay, then.
So then mainly we go to the different tests.
Okay. See, any joint examination, you have to understand the way of doing is, one is your inspection, palpation, then range of movements, active as well as passive. Active movements as well as passive movements. Sometimes the patient will not be moving, then you have to try moving active and passive range of motions. That is very, very important. Then you have to look for the special test. For whatever is there in the joint related, you have to do the special test. So whatever be the special test, you are looking in for the rotator cuff, mainly the rotator cuff, which are the structures that is getting involved. In a shoulder dislocation and all, you will not be able to do any of this special test. And another, after the special test, what we need to look in for is one more thing, is the distal neurovascular compromise. That is what you need to look in for. So special test, you can tell what all things you want to look around the shoulder joint.
So for this test, patient added an empty can.
Okay, now what all muscles that or the tendons that you wanted to examine, you can just tell. So rotator cuff comprises of
supraspinatus, infraspinatus, teres minor, and you have a subscapularis.
Subscapularis. So the common mnemonic that we all learn
sits.
So but you have to say what S is exactly for.
Oh.
Supraspinatus, infraspinatus, teres minor, and subscapularis. Now each one of their job you have to tell. What is the role of supraspinatus?
Supraspinatus helps in overhead abduction.
So initial above 90 degree.
Above 90
Till 90 degree, which one help?
It's mainly done by teres deltoid.
Deltoid. Then okay. Next one is your infraspinatus.
Infraspinatus helps in external rotation.
External rotation, and teres
Teres also
minor.
Minor also helps in
external rotation. Infraspinatus.
Infraspinatus helps. It is
Sorry. Subscapularis.
Has internal rotation backwards.
Internal rotation. Okay. So that is the movements that you need looking for. You call them any empty can test, or you call the knee test, whatever be the test, or what else is there? One drop down test. All those things, what we are looking is for how the shoulder joint, rotator cuff is working. The major thing what we are looking in for. So we can tell each one of them. Empty can test.
So in empty can test, the mainly we do a forward flexion, and after that we do a forward flexion, and we completely pronate the complete lip, and after that we will exert a downward pressure, and on exerting a downward pressure there was presence of pain, so that is indicating a supraspinatus pathology in this patient.
Okay. Then what are the other tests?
Then we can do the near test. Near test, usually it is done by we fully internally rotate the arm, and then we can look for passively in the shoulder joint whether there is any pain. But for this patient, there was no presence of any pain. So we are ruled out subscapularis. There was no presence of any
problem.
Pain, no problem.
Then empty can, you have said,
yes,
drop test.
Drop test.
You can read, no problem. You have written down, you can read. Because it's only thing what you are looking in for, you should understand. There will be a sudden drop of your hand.
Yes, sir.
Till 90 degrees, you are asking the patient to hold hand high, and you are suddenly releasing, and the patient's hand will suddenly drop because he is unable to hold the hand, which is a muscle that you should do that for that. Supraspinatus. There is supraspinatus injury, he will not be able to do that. So that is what is drop test. Suddenly the hands drops down. So that is drop test. So these are the tests that you can look in for. Any of these tests you can look in for. Remember, whatever be the movement of supposed to do that movement, you do a movement with that and try to act resistance against it. So if the patient is complaining of pain, that's a simple thing. If you remember all these tests, you remember the job of supraspinatus is this, and you try to retract that and you give some resistance opposite to that. And if the patient is complaining of pain, that tendon is injured. That's a simple mechanism by which we can easily diagnose which one is involved.
Initially, if this patient had a pain after 90 degree of when he had an overhead abduction, we did an overhead abduction, he was complaining of pain around the joint.
Now, you need an X-ray in this case.
So there was no bony injury, there was no bony tenderness, or there was no presence of any bony crepitus. But if you're considering his age,
considering his age, a small chip fracture or anything, we need not miss. A traumatic, post-traumatic. Somebody is coming without a trauma history, definitely I will not have asked for an X-ray. What are the common reason for somebody is coming to emergency room with a shoulder pain? Most common thing.
Most common,
to the emergency room, shoulder pain. Okay, I'll just put it the way. What is the most common cause of shoulder pain?
It's complete impingement.
Most common cause is a frozen shoulder.
Frozen shoulder.
Adhesive capsulitis. Most commonly seen in diabetes, obese patient, hypothyroidism. So these are the most common reasons. So they will be telling that I am unable to move, I am unable to do anything, I am unable to go and touch my back. It's very, very important history you need to
For
elicit.
this, the patients with frozen shoulder, usually even in active and passive motion, they will be having
Restriction of movements and pain. And that is the most common reason. Then you have all your impingement syndrome. So what is the management of this?
So initially we always move with conservative management. Conservative management.
Analgesics, NSAIDs is the main key.
And we can apply ice pack application for reducing of the local inflammation can be done.
Then what else?
We can give intralesional, like we can give corticosteroid injections.
When acute injury, definitely not. When somebody is coming you without a trauma history due to the frequent movements and all, you can think about all those things. The first, before that steroid injection, you can always go ahead with an ultrasonography, physiotherapy, physical medical rehabilitation, and there are a lot of tension bands available. So they will teach you exercises, how to break this capsule, specifically for a frozen shoulder. And also it should be, exercise is the most important key, and there will be local ultrasonography. There are a lot of technique which I am not aware of. They can guide you in that. Maybe 2 weeks you can give it a try. Then still the patient is not improving, then you can think of steroid injection, even PRP. What is PRP stands for? Plasma, platelet-rich plasma. That infiltration also can be tried. So there are a lot of newer modalities of treatment has come. Even lesional steroids and all, it was a previous one. Now PRP injection and all, the patient has got significant relief. And only if it is a sport person or something, you are thinking of a rotator cuff tear and he need to be actively involved in sport, definitely you need to get an MRI and arthroscopically repair needed to be done. So otherwise, routine impingement and frozen shoulder and control of diabetes, thyroid dysfunction, all these things are very, very important, and maybe a little bit of weight reduction is also very
Yes. By ultrasound wise, we use ultrasound of the shoulder
diagnosis.
For the diagnosis.
I am saying sonic guided therapy. I am not saying ultrasonography for the diagnosis of shoulder joint.
Yes.
There are like heat waves and all, they will use it around the shoulder joint and they will get resolved.
Yes,
Okay, fine. So shoulder joint pain, frozen shoulder, impingement, these are the most common thing. But if it was a post-traumatic, we have a tendon injury.
Neuromuscular deficiency.
Neuromuscular deficit, definitely we need to look for. What we have to look for? Neurovascular. Around the shoulder joint, one area I am telling you, you can examine in one area. I am telling you, you are supposed to do test only in one area.
there's a
Regimental badge area. This is the area. That's the only the area I am agreeing, that is the area. This is all you have studied in a NEET. Same thing.
So there was no presence of any paresthesia, or there was no number.
And always look for other injuries associated with a fall-on and outstretched hand. Elbow injury and distal radial fracture and scaphoid fracture. These are all very common with a fall-on and outstretched hand. And definitely this fellow might be osteoporotic. So you need to, after this treatment, you have to think about giving him calcium supplements, vitamin D, maybe bisphosphonates, not during when he has a fracture. He don't have a fracture, but definitely we can give it later.
We have taken an X-ray. There was no presence of any fracture.
Okay, fine. Thank you.